Hi everyone, my name is Ferdos Nipu, and today I'm going to be presenting to you a very interesting case on failure to thrive secondary to a rare genetic mutation. So our patient is a 3-month-old female born at 30 weeks gestation to a consanguineous couple in Egypt. Her father states that she's been experiencing difficulty breathing, nasal congestion, rhinorrhea, and multiple episodes of non-bloody, non-bilious emesis. During the first 4 to 5 weeks of life, the father states that patient was not gaining weight despite changing formulas and trialing several different bottles. The patient has dysmorphic facial features and a cleft palate, but her family did not have access to the preferred bottle nipples in Egypt. At around 6 weeks of life, she started having choking spells while feeding, diarrhea, vomiting, fever, and she was admitted to the hospital in Egypt. During her hospitalization, she reportedly had sepsis with anemia and thrombocytopenia. She required multiple blood and platelet and plasma transfusions. Ultimately, her father was unhappy about the level of progress that his daughter was making, so he decided to come to the United States. Upon arrival to the airport, he called 911 and patient was brought to the emergency department for further evaluation. The patient's father served as the primary historian. Her past medical history was notable for cleft lip, cleft palate, PFO, VSD, tracheomalacia, GERD, and pulmonary hypertension. She came in with the oral gastric tube in place. She has no known drug allergies, and her medications included L-carnitine, vitamin D, folic acid, and cefiximine. She has an older sister with a cleft palate. She lives with her father, mother, 3 siblings in Egypt, and she has no known exposure to smoke in the home. She's also up to date on all of her immunizations. So at first glance in the ED, you can tell that she looked very cachectic appearing. She looked much smaller than her expected age, and she was very grossly dysmorphic in appearing. Her eyes were notable for significant hypertolerism, and her head was very small. She had depressed nasal root. She also had bilateral hard and soft palate clefts. She also had slight retrognathia. She was also stridorous upon agitation. Her skin exam showed paucity of palpable subcutaneous fat throughout. On her neurological exam, she had slight truncal hypotonia and slight distal hypertonia. She was unable to track object faces or light. Her labs came back positive for elevated potassium of 6.1, calcium of 10.8, AST of 37, ALK phos of 156, and total protein of 7. She had elevated hemoglobin of 16.4, an ammonia level of 73. Her respiratory virus panel came back positive for rhino and enterovirus. She also had a total and free elevated carnitine level, which we noted to be most likely due to her home medication regimen. Genetics was consulted for dysmorphic facies, and they ordered a rapid whole genome sequencing. Due to the complexity of the patient's presentation, once the patient got to the floor, multiple specialists were consulted. ENT was the first to evaluate the patient for stridor, and they performed a bedside laryngoscopy, which demonstrated mild laryngomalacia. Cardiology ordered echo, which demonstrated a small atrial septal defect with left to right shunt. EKG was normal. Ophthalmology also seen the patient, and they noted slight left optic nerve pallor on posterior examination, consistent with possible atrophy of both eyes. Later, the patient was evaluated by ENT and plastics, and they performed a formal lip-tongue adhesion to ensure airway patency. Patient was later successfully extubated in the OR and transferred back to the NICU. She had several imaging studies done. Of note, her abdominal x-ray showed dilation of bile loops and possible pneumatosis. Her chest x-ray was positive for multifocal pneumonia versus pulmonary edema. She had CT head without contrast and 3D reconstruction, which showed cleft palate and mild retrognathia, which we can see on the image to the right. She also had prominence of lateral ventricles. Her cranial sutures were open. Her upper GI fluoroscopy showed trace GERD, but no evidence of malrotation or gastric outlet obstruction. So as far as differential diagnosis goes, we had several things that we thought about, right? So for example, drug-induced fetal malformation. The mother's medical history is completely unknown, so this is something that we need to keep in the back of our mind. Also, we thought about the different aneuploidies like trisomy 13, 18, 21, all of which can easily present with cleft lip, cleft palate, ASDs, heart defects, microcephaly. The same thing also for fetal alcohol syndrome, which we also kept on our differential because of the hypertolerism that we seen on the physical exam. Another thing that we considered less likely, which was Beckwith-Weidman syndrome, because on her exam we did not see ear pits or ear creases. DiGeorge syndrome was also included, right? Given her cleft palate, her dysmorphic facial features. We also considered Charge syndrome, given her heart defects and her poor development. And then also, there's many disorders for inborn errors of metabolism, such as PKU, such as galactosemia. So all of those we also considered. And then even even congenital heart disease can also explain her failure to thrive. So those are some of the things that we kept on our differential diagnoses. So eventually, the patient's rapid whole genome sequencing results came back, and it came back positive for a homozygous pathogenic variant in the neuroblastoma amplified sequence gene. So I'm sure not many of us have ever heard of this before, but basically this gene codes for a protein, and this protein is involved in mediating vesicular transfer between the Golgi and endoplasmic reticulum. This protein, the NBAS protein, is actually found all over the body, in connective tissue, the eye, brain, liver, lungs, spinal cord, bone, everywhere. So upon literature review, we found out that patients with similar mutations, they have also presented with microcephaly, craniofacial abnormalities, growth restrictions, and specifically optic nerve atrophy, which she did have. And a lot of these patients, they also presented with immunodeficiency, and a lot of these patients, they also suffered from severe intellectual disability. Given the patient's NBAS gene mutation and in conjunction with her clinical features, it's diagnostic that this patient had a NBAS gene-related disorder. Thank you for your attention. Here are our references.